Yes, yes, you are audible.
Good evening, sir. Good evening, one and all. Welcome to today's webinar. And since Dr. Behra and Madam are presently busy in some work, although Dr. Behra has joined from somewhere, he has joined, but I've been asked to just speak and speak a few words about you and to introduce you to this webinar. I'm Dr. Sushmita Singh. I'm CMO of NTPC Kahalgaon. Dr. Pawan Gupta, he's presently Director Surgical Oncology, and he has in Vaishali, Patparganj, Max Super Speciality Hospital. And Sir has performed more than 11,000 surgeries, and out of these, about 3,000 surgeries has been done on international patients. He has more than 25 years of experience, and he has done his MBBS from SCB Medical College, Cuttack, his MS General Surgery from the same college, and he has done his MCH from Gujarat Cancer and Research Institute, Gujarat University. And he has published a few books also, has won many awards, ICD International Award in 2007, and has many memberships, a long list of memberships, UICC Global Cancer Control Community member, National Scientific Committee member, NTPC Cancer Advisory Committee also. And he's a senior vice chairman, I Can Win Foundation. He has written one of the books, Win Over Tobacco, Made Easy, Be Smart, Do Not Start. Since in NTPC, we are propagating no tobacco. So this is quite an interesting book. I've gone through a few pages of this book. Welcome, sir. Without taking much of the time, I request you to start your presentation, sir.
Thank you, Dr. Sushmita, and it has been a great pleasure. And I thank Dr. Behra for inviting me for this talk. And this talk means, as usual, it is something very close to my heart. And Dr. Basant, we have been working together since I think 2018 or so, when I connected with him, and then we did a lot of programs at NTPC for on tobacco cessation and oral screening, and at Uchar we did at Dadri, at Uchar, and then at something somewhere near Allahabad. No? There is another that also we had done. So we had a lot of interaction with NTPC, and I really look forward how we can interact more and how we can take it further. So this is I'm just sharing my slides. I think it is visible.
Yes, sir. It's visible. Sir.
Yeah. So.
But it's not in slide mode. Yeah, now it's.
Okay. So what Basant wanted me to talk about is the oral cancer prevention and early detection. These are the two main important points about oral cancer. That is what he wanted me to speak to you on. So Dr. Sushmita has already introduced me. Besides all that introduction, I have been running few campaigns. Save the Youth campaign, Chota Dana, Win Over Tobacco, I Can Care, I Can Win. Be careful, not fearful, but and also be careful and fearful, and catch them early campaigns. These have been some of my campaigns. And besides that, I'm also the member Cancer and Prevention Board at NTPC. I'm the National Scientific Committee member at Rotary Action Group Addiction Prevention. I'm the Master Trainer for Tobacco Control Courses, which is done by Gujarat University. And the mentor for the Innerville Addiction Prevention Program. And we created 1,000 tobacco marshals in the last 3 months. I'm also the Health Committee member at PHDCC, that is PhD Chamber of Commerce and Industry. And just recently, I have been nominated to the Civil 20, which is coming under G20. So this has been some of the introductions and some of the things that has taken place. And I welcome you all on behalf of Max East Zone, that is Vaishali as well as Patparganj. And I also welcome on behalf of I Can Care, of which I am the founder. So I can at Max Hospital, we have got extensive tobacco means oral care as well as multiple other specialties. So I'll not go into that. So I'll just when we are talking about oral cancer, it's a World Cancer Day, and it's the close the gap. That is what we are looking for. And what is so important about oral cancer? Just look at this screen, and then you will see that the mortality and morbidity, both for oral cancers, is the highest in the world for India. So India is the leader. India has the highest oral cancers in the world. India is the highest consumer of tobacco in the world. India has the highest varieties of tobacco in the world, and India has the highest death due to tobacco in the world. So these four very important aspects actually makes our presentation as well as our the oral cancers very important, and that is why I call this oral cancer as the king of all cancers in India. Right. So this is what, and the incidence rate is almost like 20 per lakh of population, 30% all types of cancer. Over 5 people die every hour, every day because of oral cancer. That means by the time I complete my presentation, 5 people would have died. Age of effect is decreasing over years. That is another very important thing. That earlier we used to see patients at almost like 50 years, 60 years, 70 years. Nowadays we are seeing patients at 30 years, 20 years and 30 years of patients we are seeing. And this is a very alarming situation. And then another important is that 80% of the patients who come to us are either in stage 3 or stage 4. So is this oral cancer a public health problem, specifically for India? So if we have to put this criteria as whether it's a public health problem, so these are some of the criteria that has to be met. That is the disease widespread? Is the disease increasing? What individual or group to be susceptible? What causes it? Can it be prevented? And any impact of disease on individuals and society. And if you answer all these questions, you will see that oral cancer fits into the fact that it is a public health problem. If it's a public health problem, implies it really needs a lot of intervention, and every organization should take care of it. So this is important. And HPV, the cause is preventable, diagnosis is easy, treatment is curable, and rehabilitation is possible. And 26 crore people use some form of tobacco. And this is another very important thing, that 13 crore are suffering from submucosal fibrosis, a disease by Indians for India. Right? Nowhere else in the world do we have such submucosal fibrosis. It is just for the India. And this is what we actually see in our general clinic. This is generally we see such adverse cases. These are all old. You see, these are all 2004, 2005 cases. It's almost like a decade old patients. And this, you will see, patients used to come in a very, very late stage. And we had to do very extensive surgeries, bring multiple flaps, multiple things. And it was the patient's morbidity was very high. After the treatment, the patients were living in a very morbid conditions. They could not go out. They were. And these are some of the facts that we see, such extensive disease that, and everyone who was taking tobacco will have some of the other problem. So you can see how difficult and what was the problem that we are facing. And of course, it's not that it has all these things have ended. We still see such patients coming into our clinics also. But this situation is no more. We see such patients. We do some scarless surgeries. These patients have been treated. Early cancers are there. You can see the oral cavity inside that have treated patient, and you can see it's a scarless evidence that yes, there has been some cancer. So this is the type of outcome that we are giving nowadays. This patient was just operated last year in April 20. We had the RFA flap. This is another very elderly lady who has such a lesion. We have treated her, and then you can see pre-op and as well as post-op after 6 months. And just recently we have operated on her. And this is another patient where you can see how these patients are being rehabilitated. This patient had complete change in the mandible. Yeah, here you can see the flap. And just look at this patient. These are patients who are doing really well after surgery, and they come really early, for which we can actually give some good. There is no scar. There is only one scar in the neck. Technology and skilled manpower has made a difference. This microvascular surgeries, the 3D reconstruction that we do before surgeries, and pre-op planning and post-op planning and post-op rehabilitation. So these are all, the good availability of the skilled teamwork, diagnostic workup, technology, and then association with our radiotherapy and chemotherapy doctors. So that actually the whole team that consists of oral care and oral and dental care, vaccination specialist, ICU, dietitian and nutrition, physiotherapist, occupational therapist, medical oncologist, radiation oncologist, plastic surgeon and oncosurgeon. The whole team comes together to care for this oral cancer, and this quality care brings a lot of difference to our patients. So nowadays it is just not treatment of cancer, but it is a treatment of patient where we give a good quality of life to these patients, and the quality of life is the most important, and just not quantity of life, right? So both are increased for these patients. What is the special features? When we are talking about the oral cancer, 3 very important features of this oral cancer, which actually makes a lot of difference. And if we really take care, we can really bring a difference in this problem. And India, it's an Indian problem, needs an Indian solution. So these 3 very important features is that it is easily detectable. That means we can easily detect it, easily curable, completely cure is possible, and easily preventable. In spite of that, these 3 main features, in spite of that, we are seeing patients at a very, very late stage, right? And then when the patient comes in the late stage, we hardly can do anything. We have to do all extensive surgeries which last for 8 hours, 10 hours, 12 hours. I have done surgery which lasted for 16 hours. So you see these features, actually, if we take care, and that is why probably we need to have something prevention. So when we say that it is easily preventable, we need to actually focus on the prevention and oral cancer, which is an Indian problem. And it is what I call it as the king of all cancers in India. If we all join together, we can really prevent it. What we know that the cause is known, tobacco, 90% of all oral cancers, and others is like sharp teeth, ill-fitting dentures, spices, poor nutrition, and HPV. And if we want to really prevent it, then what do we do? So just simple, stop tobacco, and oral care for these patients like sharp teeth, ill-fitting dentures, and if there are any lesions in the spices or poor nutrition, is that we just take care of that and it is done. So it's a very, very easy form of prevention. So cause is known, so prevention is easy, right? So I think every one of us can do that. We can stop tobacco, we can take care of the oral care, and that's it. So prevention, oral cancers does stop in tobacco health. So, but if there is a lesion, if something, a lot of people ask the question, "Arey, kuch nahi hota." If it is there, then it is the patient is gone, right? But if we stop tobacco, if we can prevent, if we stop tobacco, does it help? So I'm just giving some examples. Just look at this. Can you see these pictures? These are the lesions. If you will see, this is the July, August, September, October, and November. These patients continue to take tobacco, and these are the pictures which had been taken. And in December, when we intervened, we started this tobacco quit program for these patients. And just look at this. There is a complete regression of the lesion. There is hardly a small whitish area that you can see, but there is a regression of this lesion. So this is the advantage. This is something which is obvious that quitting tobacco can help a lot of patients. This is another patient. Just look at this. This is February 21. You can see a small white area. There's a varicose area. Can you all appreciate these lesions? Is there someone who can, is it possible to appreciate these lesions in the pictures?
Yes, sir.
Yeah. Okay. So these are the lesions that you can see in February. In April, this patient continued to take tobacco. He was being treated at some major hospital. And you can see in September, this lesion has extensively increased, right? This lesion has extensively increased, and even the doctors were not aware. So this is what happened in March 2022. I started treatment for these patients, and first thing we did was tobacco cessation. We gave some antioxidants. We gave him the mouth opening exercise, that is tris care, antifungal, multivitamins and microminerals, and oral gargles. And then just look at this, the patients. This was the condition when we started, and this is what happened within 3 months or so. The whole lesions disappeared. The patient was much better. The oral cavity started opening up, and this is what was the you can see the how. So just important, simple thing, proper tobacco cessation and mouth opening exercises can really bring a lot of. So this is what we started in this World Tobacco Day, World Cancer Day rather, that closed the care gap, and that is we started this pledge to advise quit tobacco, right? Pledge to advise quit tobacco to your patients, to your employees, to your relatives, to your friends, and anyone you care about, right? So we request that at NTPC also, we can start this pledge that all the doctors, everyone who are there, they will take up this issue and just advise to quit tobacco. Right? Any patient who is coming to your clinic, just advise quit tobacco. Whenever you see a person, anywhere in the world, anywhere in your office, anywhere in your organizations, just advise quit tobacco. At home, if you see someone, the maids, the malis, the drivers, anyone you see, you can just advise quit tobacco. And this simple advice can make a lot of difference in tobacco control. Now comes the prevention. The treatment part, that is we are looking at, we had the prevention, now we are looking at the early detection. So for early detection, we have this campaign, what we call it a Save the Youth campaign. And it has become it has brought a notice. The two important thing is that chota dana and no tobacco. How do we recognize, how do we detect cancer at an early stage, right? This is what it is there. So chota dana campaign, what it implies, जब भी देखो छोटा दाना, उसकी पहचान जल्द ही कराना, कैंसर को बनने ना दो नासूर, शीघ्र करो इसे दूर. I think this is a very simple intervention process कि अपने मुंह की जांच स्वयं करें, हर महीने एक बार अपने मुंह की जांच करें. और अगर आपके मुंह के अंदर कोई भी ऐसा चीज दिखाई दे जो छोटा दाना के हिसाब से दिखाई दे, जो व्हाइट पैचेस, रेड पैचेस, वेरिकोस लीजन्स, पॉलिप्स और अल्सर्स, उसका इमीडिएटली आप डॉक्टर से जांच करवाएं. So this is what we do at Max. We have started at oral care centers, and just we'll show you some examples. Just look at this patient. The vigilant eye, this patient had the oral cavity, oral mouth opening was very less. He had a small lesion in the lip, which we just operated. So this is the chota dana. It was a verrucous lesion. If this would have been left, it would have become a extensive cancer. So doing a screening program where we can detect early lesions, and then we gave him this tris care machine. This is a oral cavity, so this simple machine can be used for oral cavity opening exercise, right? So this is something important. And then just look at this more lesions. Here you can see this is one lesion which was hidden in the upper buccogingival sulcus, and patient was not aware. But when we did a screening, this lesion was picked up, right? So small lesions, and then here you can also see there is a whitish lesion in the retromolar trigon. This patient was a continuous taker, smoker as well as chewer. So we gave him some medication. You can see the teeth, how dirty it is because of the chewing tobacco. And then there are certain lesions which are making it because of the smoking. So this patient on both both sides there were lesions. So these patients were advised for quit tobacco, and these patients also improved. There is another patient, just you can see here, there is another lesion in the buccal mucosa. Simple exercise like tobacco cessation, cleaning, filing, and regular follow-up. These patients had done well. So this was another patient who had this leukoplakia, which was excised almost 2 years back in 2019, but he continued to smoke after and then he again came back with another lesion. We had to remove it. We had to do a laser excision, and now this patient is completely without tobacco and he's
Sir, kindly unmute. Sir, there is no voice.
there is no voice. Okay.
No.
So okay. So what was he's saying is that he has started in 2019. Now he's completely off tobacco because of the treatment that was given at the Icon Care at the Max Vaishali Center. So this is another lady who, because of this use of submucosal fibers, this tobacco, chewing tobacco, as well as this areca nut. So they have this mouth opening problem. So this lady also had this mouth opening problem, what we call it as submucosal fibrosis. So we gave this exercise, and this exerciser has been able to help him to open her mouth by almost like 1 to 1.5 centimeters. Right? So this is the instrument, what we call it as Triscare. So oral cancer control implies the healthcare professionals, public awareness, that implies that we definitely require an oral care and a tobacco cessation specialist available at every place. So one intervention can change the world. That is what I believe in. And this intervention is basically we have to, tobacco in any organization should be controlled. Almost if you look at the rampant use, 30 to 40% of all people working in any organization use tobacco. All tobacco users are responsible for most health issues. Major part of health budget used by these tobacco users, and more importantly, it is a preventable disease. So if we can take just simple measures at NTPC, we can save a lot of money for NTPC. We can save a lot of lives, and the money is not in just few thousands. It is in crores that can be saved. And this was a cancer trend in one of the PSU. And if you see the trend, you will see that most of this cancer, the highest number of cancer is because of the tobacco. If you add all of them, head and neck, lung, oral, then pancreas, esophagus, the renal, all this cancer, the urinary bladder, all these cases when added together actually are the highest for all the cancers. But and it's just not the cancer which is important, but if you look at most of these organizations, most of these patients will those who are using tobacco will have heart disease, cardiac problems, the pulmonary problems, which increases or which brings loss to the PSU. So if you just look at the economic impact of all these diseases, which is from lakhs to crores of rupees, just look at cancer. If it is detected as a pre-malignant lesion, the cost is around 10 to 40,000. If it is stage 1 and 2, it is still curable. It is 1 to 2 lakhs. If it is stage 3, it is potentially curable. The cost is 4 to 10 lakhs. But if it is stage 4, incurable, cost can go to 10 to 1.5 crores, and the patient suffers and spends till death. And who is bearing all the cost? It's the PSU which bears the cost. If there is a cardiac problem, if the hypertension, the patient will be on lifelong medications, which will cost crores of rupees over a period of time. Angioplasty, it may be just 4.8 lakhs, but then the medications are going to cost crores. Stenting cost may be just 3 to 4 lakhs, but the lifelong medication. So it will be crores of rupees, which is put in for one such patient who is taking tobacco. If it is a stroke, hypertension, lifelong the patient is crippled and the cost is again in crores. If it is a respiratory problems, the patient is always fatigued, he's crippled, he'll require BiPAPs or ventilators, again the lifelong medications, which will again cost crores. These patients who take tobacco in any organization spend and suffer till that, drain all the budget, but all the budget of the PSU. And most importantly, it is very sad, but it is a preventable disease. If we can only take some certain measures, it can be easily controlled. So this is one of the PSU experience. In 1998, we had seen that almost 50% of the patients who are taking tobacco have some or the oral lesions. This was in one of these 1998, in 1967 factory workers, we had 700 oral lesions. In one recently in the 2019 in PSU, this was again in one of the NTPCs, we had 162 patients were examined, 71 had oral lesions, pre-malignant lesions likely to become cancer. And recently we had this in ONGC, we examined 13 patients, 35 had oral pre-malignant lesions. So this is very rampant. And the important thing is that if we can take care of them at the right time, probably we will be able to cure them, we can help them, and we can save lives. So financial implications is very high for each disease, and the root cause for all these CVD and cancers are tobacco, and maybe a little bit of lifestyle or diet and stress. So just another example how a smoker actually is putting loss to the company. Just look at this. If a patient who is smoking and if he takes 6 breaks, that is 1.5 hours every day. So total in 1 week, 7.5 hours, wage per hour is approximately 200. Then wage lost per 1 week is 1,500, and in 1 month it is 6,000. So if there are 1,000 employees who are smoking, so it would be like 60 lakh rupees per month loss is there, and it will be something at a huge amount of loss per year. This is something that I want all of you to understand and take something that a revolution is required in every PSU, so that we can bring a change and this tobacco can be controlled. The high health budget of public sector undertakings in India is a concern, and the only reason is the most of this thing drained out because of the tobacco users. Single intervention can change the budget, it can save money, it can save lives, and that's where the Save the Youth campaign can be adopted at all the centers. So building a healthier community, tobacco control is very important, and I think it is easy said than done. When we talk about, since most of you are doctors, the simple intervention that to tell the patients to quit tobacco, if it was so easy, then probably everyone would have quit tobacco. So most of the time the question comes up, doctor, don't tell me why, tell me how. So this is where we need to work, and this is where the Save the Youth campaign comes in. That is, we sensitize, we assist, we volunteer training and enforcement. That's the complete Save the Youth campaign. That is sensitization for the public, sensitization that tobacco is bad, sensitization that please do not be friends of tobacco users, sensitization that please do not employ a tobacco user. Assistance for those who are already taking tobacco, we help them through digitalized program so that they are able to completely quit tobacco. And the volunteer training programs are for marshals, ambassadors, and specialists, creating ambassadors. And this is where we do an enforcement program. Once we have put everything into place, we go for the enforcement program that to make every place a completely tobacco free. So why tobacco is such a difficult thing to quit? It is the most addicted substance in the world, most easily available form of addiction. It is the cheapest addiction. The industry is working overtime to make it available and entice the youth. It is the gateway to other addictions, and our children are at risk. Nowadays, the girls and even women are getting into it. So this is an important message for everyone. And this, I want all the doctors here to please understand and to please note that the medical treatment is available to quit tobacco. That is the most important development. Earlier, maybe around 5 years, 10 years back, we had no medications. We used to only depend on talking to the patient, giving them counseling and asking them to quit tobacco. And most of the patients who had withdrawal symptoms or cravings would actually relapse. But now with the medical treatment available, it is possible to quit. standard protocol for intervention is available. Specialized tobacco cessation specialists are now available. Specialized centers, both physical and virtual, are available. Right? Tobacco quit program is available, feasible, and effective. Make it effective. We at ICANCare, that is where I am the founder, we have started a digital protocol-based intervention with simplified with AI components by certified tobacco cessation specialists, skilled and confident to help you quit successfully, and no quackery is there. And this is the balance that we make for a successful program, where we are giving pharmacotherapy, behavioral intervention, withdrawal management. This comorbidity management is there, and every patient is individualized, and we are treating these patients. So at ICANCare, we have got all the system set. We have got the app, we have got digitalized protocol, we have got tobacco wellness centers, trained certified tobacco cessation specialists, self-help materials, e-pharmacy is there, quit coaches, central quit line, community network. All things have been put together. And for the first time in India, we started a tobacco quit line, private quit line, which is 011 430 77695. This is how we do. We have this virtual clinic. Those who are not able to reach our physical centers, we have started a virtual program for them. We do a virtual clinic, we do a telephonic program, and we have this e-pharmacy. That is, we deliver the medications at the doorstep, so that patients do not say that they did not have the medicine and that is why they have relapsed, or that is why they could not quit. So this is also we have started. We have a digital protocol, simplified intervention methodologies, and we do a regular follow-up for these patients. Tobacco cessation help books are available, and of course, as I've said, our quit line number is there, where anyone can call in and we can help you out. 011 430 77695. So this is the e-pharmacy that I have already spoken, medication at the doorstep for better compliance. And this is our number, assistance for tobacco quit line number. Every one of you can take this down. So we are here to help you out in at that ICANCare will be there. And with the digitalized program, it is actually been able to reach out, help, and assess, do AI investigation, and we are able to manage the withdrawals, cravings, and help these patients in completely quitting tobacco. So these are some of the books which have been written by me and into multiple languages, just basically focusing on tobacco cessation. That is, first book is Be Smart, Do Not Start. The second is Win Over Tobacco is Easy. The third is basically a tobacco cessation, a comprehensive guideline. And the fourth, which may be very important or may be very interesting for all of you, that is Making an Institution Tobacco Free, a basic manual, how to make your institution, that is NTPC tobacco. So we also started this capacity building for tobacco cessation, that is training the doctors in 3 different levels, at the marshal level, ambassador level, or cessation specialist level. And this is how we look forward, that if we can train all of your doctors at NTPC, we can collaborate and make a wonderful tobacco cessation program. So these are the steps, or these are the way the marshals, ambassadors, and specialists, this is the multi-step process that we do, so that everyone understands, and whoever wants to be in whatever level, they are able to make it. So this is how we are able to actually create a difference in the society. So I am just asking, I am sure all of you would be interested into this. So what intervention we can do, that is what we can do together, how we can make a difference, that is set up a tobacco vigilance, tobacco wellness center, that is set up I can get digitalized tobacco users and oral care centers in all your units. We can create tobacco marshals. We can train them as HR, securities, and social workers who are there. They need to be trained. Sensitize all doctors. We can have a sensitization program specifically on tobacco cessation. What are the methodologies? Tobacco cessation is not easy. We need to understand the complexity, and if we can actually do an intervention, it will definitely, if we can train the doctors, it will definitely work. And also we can work with you for the virtual tobacco cessation program. To save the youth, it is our responsibility. So if all of you are there, may I request that if you can just click on this QR code and join the ICANCare Facebook page, so that we can remain in touch. So if you have joined, then let me know so that I can proceed further. Just click the QR code and you can join. If once done, then just tell me so that I can proceed further. Is it done?
Sir, please proceed. Will
Yeah.
Sir, please proceed. You can send it, sir, in a mail. I'm unable to click it right now. I think most of us, I don't know why, but I'm unable to click it. Scan the QR code.
Okay. So is my how do I proceed? I have got connected.
Actually, sir, most of us have joined from the mobile phone.
Is my this thing visible?
Yes,
Is
sir, it's
my
visible.
screen is visible.
Yes, sir, it's visible, but it's not in the slide. Now it's in slide share mode.
Okay. Right. So we created, this is just some of the examples that we are setting up. So we created around 1,000 marshals in 3 months time over a period of at certain areas. And now we are looking at creating 10,000 marshals in every organization, PSUs and institute. And these are some of the examples how these tobacco marshals are working in the society. And this is where we can also uh, connect with NTPC to do something in the society. These are the tobacco marshals who are doing in the schools, village schools. These are the teachers who were trained as tobacco marshals, and then they went into the villages and they did a lot of work. And these are young girls from villages at around Muradabad, Amroha, and other areas. And we trained them at 550 girls we trained who went back to the rural areas, and they are working in the society for to help people to understand tobacco and quit tobacco. एंड दिस इज द युवा ग्रामीण लड़कियों को प्रशिक्षण देने से युवाओं को तंबाकू की लत से बचाने के लिए ग्रामीण क्षेत्रों में उनकी पहुंच बढ़ेगी. दिस इज व्हाट इट इज बीइंग डन. And these were the young, these are the social workers, the females from the Innerville Club, almost like 350 of them whom we train to be tobacco marshals who are working in the society. So this is what I would suggest, that yes, we can work together. ICANCARE and NTPC, we can actually create together, we can make your NTPC an organization completely tobacco aware as well as tobacco free. So we need to set up tobacco cessation centers. We have to create tobacco marshals. We have to get together all those patients who are taking tobacco. We need to guide them and train them. All the doctors need to be sensitized. And then last but not the least, what I put up this slide, that let us join hands to close the care gap. Let us pledge to advise quit tobacco. Every one of us, let us pledge. I would request that please take a selfie and put it on your social media, saying that yes, just with hashtag of advise quit tobacco, and so that we are all here to help the society. Thank you so much. I think I'll stop here. Thank you so much.
Thank you, sir, for a very enlightening presentation. And technology has definitely made a difference. And since this is a very easily detectable, easily curable, and easily preventable cancer, so, and all of us are trying in NTPC to reduce the consumption of tobacco, but so far we have not been very successful. With your help, we can at least decrease it And I request you, sir, to please share that QR code with Dr. Behra, and he'll be sharing with all of us, because at least I was not able to scan the code because I have joined from a mobile and I did not know how to scan it from the same mobile. And many things have been new to me. I'm a gynecologist basically, so I'm not very much aware of oral cancers. Although last year, with the help of TMH, we had organized many programs for detection of oral cancer, but still we were not aware of the newer things. And since treatment is available, and with the digital platforms, we can definitely make a difference. Thank you, sir. Any questions?
Namaskar, sir. I am Dr. Larry Simo, NTPC Hospital, Ramagundam. My question is, sir, what is the relationship of alcohol and tobacco as a causative factor for occurrence of cancer of oropharynx?
If a person is using alcohol and tobacco, the chance of cancer is increased to 118 times. 118 times. Alcohol actually increases the formation of cancer because the tobacco, which is containing a lot of carcinogens, they penetrate into the cell, and that is how the alcohol helps in increasing. If a person is only using tobacco or he's taking tobacco, the chance of having cancer is 19 times increased. The risk is increased 19 times. If a person is taking tobacco, just alcohol, his chance of having cancer is only 9 times. But if a person is taking both alcohol and tobacco, the chance of having cancer is increased to 118 times.
Thank you, sir. I have one more question, sir. What is the incidence of oropharyngeal cancer in patients with submucosal fibrosis, and how to prevent this occurrence of submucosal fibrosis, and what is the ideal treatment strategy for the submucosal fibrosis?
Please repeat your question.
Yes, sir.
Please repeat your question.
What is the incidence of oropharyngeal cancer in patients with submucosal fibrosis, and how to prevent the occurrence of submucosal fibrosis, and what is the ideal treatment strategy for the submucosal fibrosis?
So can I have your background? You are from which discipline?
I am surgeon, sir. Surgeon NTPC Hospital, Ramagundam, and same also.
Okay, wonderful. So, Doctor, how does the submucosal fibrosis happen?
So there are so many causative factors. One of the causative factors is tobacco, and another one is betel nut. And there are so many chemical consumption also causes submucosal fibrosis. So does this submucosal fibrosis causes cancer? And my question is that, sir.
See, let me just put it this way. Where do you present throughout my presentation? Where do I showed this submucosal fibrosis, the TRISCARE instrument, how to manage the oral. So what is, if you know what is the cause of submucosal fibrosis, it becomes easy to manage it, right? So we know that there are a lot of interventions that can be done, but the most important intervention is mechanical mouth opening. And this mechanical mouth opening can be done with this device. I will just show you a device which I have been talking about in my presentation. Probably you missed that. So this is a simple device. Can you see?
Yes, sir. Yes, sir.
So this is a TRISCARE device, and here is the name for that, TRISCARE, right? Can you read the name, TRISCARE?
Yes, yes, sir.
So this is a simple device, and here is the device. Here there is a mark here where it is a, you can see what is the amount of mouth opening, and this simple device with which has a screw, right? Here there is a screw there, right? And this causes a mouth opening, you know, stretchful mouth opening, right?
Yes.
Right? And this particular instrument can be very, very helpful. We have been doing this with all of my patients, and they have been actually, the mouth opening have increased substantially, almost to 1.5 centimeter. The mouth opening increases over a period of just 3 months. And I have shown some examples during my presentation where we had a lot of females and a lot of people who have been using this tobacco, betel nuts and all. So the most important for all these patients is tobacco cessation. So as a doctor, Dr. Lahiri, I would say that are you aware of the tobacco cessation methodologies?
Yes, yes.
Are you aware?
Yes.
How do you do that?
Sir, my question was, does
I'm
this...
asking a question now.
Yes, sir, please.
How do you do tobacco cessation?
Sir, it depends on the this severity and since how long these patients are taking tobacco and this whether patient is in the addiction phase or it depends on the severity of this addiction.
What medicines do you give?
So we are not giving any medicine, sir. We are just sending patients to higher center for this treatment.
My request that so many of you are here, including Dr. Lahiri, my request is that please organize a sensitization program. We are doing a training program for all the doctors where we help you to understand what is tobacco cessation, how to do a tobacco intervention. Because without that understanding, I have shown some of the examples in my presentation where the patients were not given tobacco cessation, but the treatment was continuing. Without giving tobacco cessation, nothing will work, right? For all these oral lesions. So it is important as a doctor, every one of us should be aware about tobacco cessation. What is the methodologies? What are the recommendations? How to do it? So this is somewhere I would suggest that all of you from NTPC, please ask Dr. Behra to arrange a sensitization program for your tobacco cessation.
Okay, sir.
So one question, like
Please.
in cervical cancer, there is a time period from pre-cancerous to cancer, 10 to 15 years, takes 10 to 15 years from pre-cancerous stage for the cancer to develop. So is there any...
From a normal to pre-cancer to cancer?
To cancer, yes, sir. So is there any time period from submucosal sclerosis or fibrosis, whatever changes occur?
You're Dr.
Yes.
Susmita?
Yes, sir. Yes, sir.
That's
so
wonderful.
Is there...
Yeah, let me put it this way. When we are saying that there is a time period from pre-malignant to malignancy, again, these oral cancers also have a time period. And oral cancers, again, I want to tell you 3 important aspects of this oral cancer. It is easily preventable, easily detectable, and easily curable. We need to pick up at an early stage, right? So a simple methodology, doing a cervical examination is difficult for a lady. She may not be very comfortable to do a cervical examination regularly, but an oral examination can be done easily by the patient themselves and also by the doctor or any paramedics or any of the nursing staff as well. Just open the mouth, examine if there are any lesions, like pre-malignant lesions can be like white patches, red patches, polyps, papilloma, or any ulceration which is just started taking place, and just do a immediate means some intervention. So what happens is there is no certain time factor. If you are saying that it may take 10 to 15 years for a cervical cancer from pre-malignant to cancerous, but then again it depends upon whether it is a mild, moderate, or severe dysplasia, whether it is a carcinoma in situ, right? So similarly, these patients who have already developed leukoplakia can be, again, it can be mild dysplasia, moderate dysplasia, or severe dysplasia, and depending on that, the time period would also vary. There is no fixed time, but it can vary from 1 year to maybe almost like 5 years to 10 years. But these patients need to be put on regular surveillance. It has to be an intervention, a proper intervention that includes tobacco cessation, and local care of the lesion. We cannot wait for these patients to convert into cancer.
Okay, thank you, sir. Sir, एक चीज और जानना था, one more question. Is there any cost involved in that program? I can care quit line.
Yes, definitely there is a cost. Yes, definitely there is a cost involved, because means it is a very intensive program. We have doctors working for that. It is definitely there is a cost involved for that.
So it can be shared with the contract workers also, I suppose, sir, because most of the tobacco chewers in the project station are mostly the contract workers, and we do find many precancerous lesions, and these are the people who need guidance to quit tobacco, because we are unable to motivate them. So
yeah, I can tell you, Dr. Shushmita, if you contact workers, we had this program at one of your centers where we had examined. I had put it there 173 patients we had examined. Of this, almost like 78 patients had oral lesions, right? And just let us not focus on the contact workers alone. If you look around in your hospital, in your organization, there are many people in the management in the higher level who are also into tobacco use, whether it is smoking or chewing tobacco. They need to be also guided. So if they are guided, automatically these contact workers will be forced to quit tobacco.
Yes, sir. We'll definitely like to interact with you, and with your help, I hope we'll be able to at least reduce the incidence of oral cancers, which is the king of cancers, as you said. So I'll keep in touch with you, sir. Most of the doctors I know.
It is just not the oral cancers, Dr. Sushmita, the cardiac, the respiratory, the strokes. A lot of patients from your organizations need treatment for hypertension. These are also related to your tobacco. And if you look, just do a little survey, and you will see that the most of the budget that is your health budget is being taken away by these tobacco users.
Yes, sir. Yes, sir. You have shared many of your videos in the past also with us. Now I can correlate with you, because I had seen those videos. Because being the CMO, I had to implement some of the programs. So I took guidance from those videos also. Thank you, sir, for a very enlightening program and discussion. We'll definitely, most of the doctors and those who have joined from MS Teams, and some of them have joined in the YouTube also. They must have gained a lot of knowledge, and we'll definitely take the QR code, and we'll be connecting with you later on also, sir. Thank you, sir.
Thank you so much. What I request is that we can collaborate to actually bring a substantial or a visible change in your organizations. That is where I can collaborate with you.
Yes, sir.
Thank you so much. It was a real pleasure. And in case you want to note down my number for anyone, it is 9811
9811
290
290
152.
152. Thank you, sir.
Thank you so much. We can definitely do a lot together for the society, both within and outside the organization. Thank you so much. Thank you.
Definitely, sir. Definitely, sir. Thank you, sir. Thank you once again from on behalf of NTPC and from all of us.
And you can see that I'm putting I can get tobacco marshal cap. I purposely put so that everyone get motivated that we can do something. And here is a badge also, tobacco marshal badge also.
Yes, sir.
With others that yes, there is lot that everyone can do. Just advise quit tobacco. As tobacco marshals, we need tobacco marshals each and everywhere. We need tobacco association specialists who are trained, who can actually do something. And we really want them to understand rather than just means from hearsay knowledge is not enough. Tobacco cessation is not an easy task. It needs lot of skill and lot of understanding.
Yes, sir.
Thank you so much. Sign off. Thank you so much.
Yes, thank you, sir. Thank you. Now I invite Dr. Rahul Bhargava. He is a leading Indian hematologist and hemato-oncologist, and he's a principal director and chief hemato-oncology and BMT. He's a leading Indian. He has many firsts to his. He was the first Indian doctor to successfully perform stem cell transplant in multiple sclerosis in 2014. And also, he has been associated with many other things which has been started in India for the first time with his under his guidance. He's also the first Indian doctor to have successfully treated stem cell to have successfully done stem cell transplant for treating systemic sclerosis, and a path-breaking anemia clinic for the integrated treatment of anemia-related disorders was also conducted under his leadership at FMRI. He's also credited with having established 14 low-cost BMT centers pan-India and with excellent outcomes. Dr. Bhargava, he has performed more than 1,200 BMT procedures, and he has a very long list of work experience. He has been associated from 2005. In 2005, 2006, as a senior resident in hematology in CMC Vellore. Then he was in AIMS. So he has a big list. In 2021, without going through all the list, in 2021, he's the adjunct professor, ESIC Hospital, Faridabad. And sir, it is a long list of awards and scholarships. He has been the best outgoing student in MD Bhopal, best outgoing student in DM AIMS, best BMT surgeon. And of course, he was the first to start bone marrow transplant in Indore Medical College, Banaras Hindu University, and ESIC Hospital, Faridabad. Sir, without delaying this session, so I request you to start your presentation. I think I have not done the justice in introducing you because it's a big list, and I have not been able to go through all of it. Sir, you are muted. Sir, you are muted. Sir, you are not audible.
Can you hear me now?
Yes, sir. Yes.
Perfect. So, friends, thanks to Dr. Bera, thanks to NTPC. I've got no presentation to tell you, okay? For next 15 minutes, I'm going to tell you what I do. what Dr. Pawan told you all about as a preventive strategy for cancers. I'm basically a hematologist and a blood cancer specialist, and there is no preventive strategy for me. मेरे पास कोई preventive strategy नहीं. I don't have any preventive strategies for prevention of blood cancers. And blood cancers, you understand there's a bone marrow in the body of any specialty you're working. So I'll cover 3-4 things for you. What is blood cancer? How does it happen? What you need to do? And what kind of a doctors you need to understand who is who so that you can send the patients to the right people. Okay. So there is a bone marrow. Bone marrow has got red blood cells, white blood cells, and platelet. If there is a low hemoglobin, that can be because of colon cancer. That low hemoglobin could be iron deficiency anemia. That low hemoglobin could also be multiple myeloma, or that low hemoglobin could also be myelodysplastic syndrome, depending upon what age you are dealing with. So there's a lot of talk about preventions, carcinoma colon, carcinoma cervix, head and neck cancers, and so on and so forth. But how do you diagnose them early? That's the question. So one-liners, if you have recurrent back pains, dear friends, recurrent back pain, high ESR, think myeloma. If there's an elderly gentleman, say 50 years onward, where there's MCV, there's a component of MCV which is high, that could be myelodysplastic syndrome or megaloblastic anemia. You need to do a bone marrow test. If your hemoglobin is going down, your WBC counts are going down, your platelets are going down, there's a pancytopenia, please do a bone marrow test, because that's where you will pick up blood cancers early. Very simple. So the blood cancer originates from the blood itself, even the myeloma, even the lymphomas. It is just that the lymph nodes which grows in size, you are able to see, and that's called lymphoma. So anybody who has got lumps and bumps, please come to you. Don't neglect it, say normal hai. Nothing to be done. What are the symptoms? Plain simple, sir. Fever. If I have to introduce my department to you, at Fortis, we are one of the largest, I was certain not one of the largest, but the largest bone marrow transplant unit in the country in 2022. A calendar year, we have done almost 230 bone marrow transplants. Where we need to do 500 transplants because that's what the population demand is. We have got infectious disease specialists. So any of your unknown fevers or pyrexia of unknown origin, 15% people do have lymphomas. They could have myelomas. They could have MDS. They're diagnosed as leukemias, CMLs, or CLLs. So if your fever is not going down in 2 weeks, you have to remember to have an ID specialist, infectious disease specialist, which is there with us. I don't know whether you take care of the elderly people or not beyond 60 years of age, but now we have got a geriatric doctor who takes care of them. Or we have got not only one ID specialist, but 2 ID specialists. So please pick up your calls. And if you have any problems with infectious disease specialists, you can always talk to them. And we will come back to you end tuberculosis, the way we are educating about head and neck cancer, the similar way we are going to talk about NTB, pyrexia of unknown origin, and so on and so forth. Then we have got geneticist, which is a new entity where you can do a genetic counseling. Of course, cancer will occur. But can I prevent it? Do I have an inherited risk? And does my genes tell me how to tackle it better? That's why we have opened up a genetic clinic with us. Dear friends, throughout the country, just ask yourself, have you ever heard of an ID specialist, geriatrics, geneticist, pediatric, hematologist, nutritionist, psychologist, physiotherapist under one department, not under one hospital, but under one department. And that's what it makes us unique. So whenever you are working throughout the country, NTPC, my simple, humble request is, when it comes to hematology, you have to remember Fortis FMRI. All these are DM. They have done MBBS, then MD Medicine, MD Pediatrics, and then they have done their DMs. In India, there are 2 types of DMs. One is from a pathology background. One is from medicine background. Or then there is a DNB or the DM. And all these people are DM from AIMS and other good places, from Calcutta, PGI, and so on and so forth. And CMC Vellore, of course. So you see the robustness of a department for a blood cancer. And remember one thing, please tell your people and spread this word that in blood cancers, you require multi-speciality consultation. You need a cardiologist. You need a nephrologist. You need a critical care, which is not there in the standalone cancer hospitals. Even a center in Mumbai, if you have to do the dialysis, they refer it across the road. And 20 to 30% people will require dialysis. They will require cardiac problems. Who sees them? That makes the outcome different. And that's what we are proud of about our outcomes. 70 to 80% people survive. So symptoms of fever. We started with fever, unknown fevers, weight loss, night sweats, lumps or bumps in the body, abdominal pain leading to splenomegaly. Many of your splenomegaly goes to gastro. They need to come to you, hematologist, to know what is the cause. Then feeling weak, fatigue and tired by the end of the day. Every day the hemoglobin is coming down. Your worker at the age of 50, his hemoglobin is coming down. And with Dr. Pawan around, he must have gone, but I would have interjected that those people who chew tobacco, tulsi, rajnigandha jo lete hain, they do have a vitamin B12 deficiency because nicotine also leads to less of absorption of vitamin B12. So once you are screening them for an oral cancer, please give them the vitamin B12 also for 3 months. The simple test which you require, please, my friends, and my number will be there. We have started a service called clinical annotation. If you have a problem with CBC, please tell us. So low MCV, low MCH, prolonged RDW is iron deficiency. Low MCV, low MCH, normal RDW is iron deficiency or thalassemia trait. So CBC report which comes to you can actually diagnose you for iron deficiency or vitamin B12. And once we have a time, then we'll have approach to anemia as a program. I'll show you 10-15 cases and you have to diagnose them. In the meantime, if you have a problem with the WBC or CBC report, you can WhatsApp us. And 30 seconds you can get an answer. So simple gateway for a blood cancer to diagnose them early is CBC. And I say, be intolerant to your body. People say, we are intolerant society. I say, we are the most tolerant society in the world. The mere fact is that we are tolerant to our own body signals. We don't listen to them, my friends. So if a 55-year-old gentleman who comes with a hemoglobin of 5 and say MCV is 121, what will be your diagnosis? Anybody can open up the mic and say, 5 hemoglobin, MCV 121. What will be the diagnosis?
Folate deficiency or vitamin B12 deficiency.
That's one. Second. There has to be a second differential also. Autoimmune hemolytic anemia.
Myelodysplastic syndrome.
After ruling out B12, ruling out autoimmune hemolytic anemia, then it is myelodysplastic syndrome. Say one person comes, young female who has just joined with you at the age of 28. Her hemoglobin is 10.2, MCV is 60, MCH is 23, and RDW is 14. What will be a diagnosis? She is from West Bengal.
Iron deficiency anemia.
Very nice. That's a let's put this, sir, as microcytic hypochromic.
Yes.
Now, microcytic hypochromic, sir, RDW is normal.
The thalassemia trait.
Yes, very nice. So you have to counsel her that after marriage and before pregnancy, you have to start iron, or you have to counsel them for thalassemia checkup with a spouse. And if the spouse is also thalassemic, then you have to check the baby when the baby is within 3 to 4 weeks or 5 weeks within the pregnancy. Okay, it's a 50-year-old gentleman, male who comes with a hemoglobin of 7, MCV of 65, MCH of 25, and RDW of 23. Diagnosis.
Anemia of chronic disease.
No, RDW is prolonged. He's 50 years old. Of course, you will find out the anemia of chronic disease, but you will also do the iron profile. Iron profile was low. There was an iron deficiency. What do you do then? If a male of 50 years old from an NTPC who develops an iron deficiency, what will you do next?
Two local blood test.
Two local blood test. Two local blood test has got only 60% sensitivity. So you have to do a colonoscopy. And this patient actually turned out to be a colon cancer, stage 1. So you see how anemia can lead to a diagnosis. So there was no way to prevent MDS, because as we live longer up to 85 years of age, we will have all these problems coming up. So you have to look for the symptoms, and the CBC is the simplest thing. Then you do a bone marrow aspiration and biopsy. The report tends to come in 24 to 48 hours. You don't have to wait for 72 hours. There's a test called flow cytometry. Flow cytometry helps in characterizing the type of a leukemia. So now we have got a hematopathologist for 8 years with us, who has been working with us for 8 years, from Artemis to Medanta to Artemis to Fortis, who gives you a diagnosis specifically for hematopathology. So very, very important, sir, that hematopathologist needs to be within house. So when you choose a hospital to send, you should ask whether there's a hematopathologist there who will answer my queries for hematology. And every medical oncologist is a hematologist by default. But every hematologist is not medical oncologist, sir. I don't do colon cancers. I don't do breast cancers. But I definitely do leukemias. So these are the commonest symptoms which you have: weight loss, fever, splenomegaly, lymphadenopathy, low WBC count, low hemoglobin. And it can affect anybody. People ask, sir, what age it will affect? I say, if love can happen at any age, then blood cancer can also happen at any age. So let's not worry about the age. If I'm 40 pass kar gaya, I will not have this. You can have anything, anytime. Now it's a conglomeration of the diseases, sir. And the diseases depends upon the genomics. So now there's a package. So now you have a problem, say high WBC count. You say it's an AML, looks like AML. So what all tests will you say? And why you should be aware where the cost comes in. Bone marrow test, 7,000 to 8,000 rupees. Flow cytometry, 10,000 to 12,000 rupees. Genomic test, 12,000 to 14,000 rupees. And cytogenetics, 5,000 to 6,000 rupees. These are mandatory, and blood cancer has got no staging, sir. It is not like a head and neck cancer or breast cancer where they should ask for staging. There is no staging. It is either good or bad depending on your genetics. My nose is different than your nose. Many of the males must be more beautiful than what I look. The only reason is genetics, genomes. It's a genetic material which decides how my disease would be. And what are the diseases of WBC? AML, ALL. Acute myeloid leukemia, acute lymphoblastic leukemia. Because genomics will decide what kind of a targeted medication I can give. From a pan-bomb approach to a targeted approach I can give. And to us as a hematologist, the simple classification is the patient transplantable or the patient non-transplantable. Does the patient fall into a high risk for doing a transplant versus not doing a transplant? And I'll tell you a figure. 80% of solid cancers are palliative in nature. They will keep on treating you. In hematology, 80% cancers are curable. So that is why I say you need to pick them early. That's why we have put in slide scanners, digital slide scanners for the first time in the country in Gorakhpur, where 3 days back one patient was screened, looked like APML, picked up by my hematopathologist sitting in her comfort of a room, digital scanner there. She makes a diagnosis of APML, airlifted from Gorakhpur to Fortis, now becoming better. APML has got high mortality. So communication, my friends, I will request Sushmita madam, Dr. Sushmita and Dr. Behra and all the group who's there to communicate. I know everybody is busy, but that's why we are the partners for you to save lives. I was talking to an American friend. PGI Chandigarh has published a paper where there's only 50% survival post-transplant. I was asking, what is your survival rate? In US, they say 80%. Why there's a gap of 30%? Because we are not picking it up early, because we are not being trained to think of a blood cancer. We are only trained to think that blood cancer is a death sentence. A word on treatment. CML, oral medication, imatinib, dasatinib, nilotinib, oral medication can be done. What is CML? Presents with high WBC count, normal platelets, spleen enlarged. You give medicine. Do BCR-ABL at 3, 6, and 9 months. Patients survive for 65 years of age. In CLL, as we grow older, we keep on doing our blood counts. We suddenly see lymphocytosis. Neutrophil is 42, 58 is lymphocyte. That's CLL. Does a flow cytometry, but all CLL does not require treatment. They all don't require treatment. Now, dramatic presentations of AML, ALL, bleeding from nose, mouth, TLC 60,000, platelet 20,000. It is AML or ALL. We need to do a flow cytometry. Similarly, lymphomas. You need to do a biopsy. Always do a biopsy, which is non-Hodgkin's and Hodgkin's. Hodgkin's, our own survival rate is close to 95%. Non-Hodgkin's lymphoma, DLBCL, 60-70% people get cured. So you see how the progress is happening. And majority of time, you don't need to be admitted in the hospital. You can get the treatment outdoor. So you save money also. So from a pan bomb-like approach where we were killing everything, now we have moved on to a targeted approach where we are only killing the bad cells. And what is the future? Future is regeneration of on your own T cells, which is called CAR T cell. So I take out the T cells from you, genetically modified, put it back inside your body to kill the bad cells. So if you can be happy, if you do yoga, if you do pranayam, you can activate your T cells.
Hello.
Yes. So CAR T cells are coming in, which means multiple myeloma patients who were surviving for 2 years, now they are surviving for 8 to 10 years. Multiple myelomas are very simple. Unexplained renal failure, multiple myeloma. Unexplained anemia, serum protein electrophoresis. Back pain, high ESR anemia, serum protein electrophoresis, myeloma. Think myeloma. I know you'll be burdened with all the thinking which you have. And I'm sure half of them will require a drink to digest all the information. But don't worry, sir. Simplest thing is you have a hematologist on board now with you. Your neighborhood Spider-Man. And a word on bone marrow transplant. We do largest number of bone marrow transplants, more than CMC Vellore, more than Tata, more than AIMS. And what do we do in that? We take out the stem cells, keep it with us, put in the chemotherapy, kill all the bad cells, and put the stem cells from the veins itself. There is no surgery. I am not a surgeon. Blood bank takes out the stem cell like platelets. If it is self, like myeloma, lymphoma, neuroblastomas, then it is called autologous. When it is from brother, sister, it is called allogenic. And there's a special test called HLA. There's a special test called HLA. So I have got my mother had 7 brothers, sisters. I have got 1 brother. And my son has got only 1 sister, which is called hematology. So how will they get an HLA typing done? The simple is that you can search in the registry, or you can do a half match transplant, which costs 20 to 25 lakh rupees. And the success is 60 to 70. And ever increasing success rate going up to 80 years is what we think this year will be. So that's bone marrow transplant. So by the end of the day, if you are diagnosed with leukemia, there is hope. And many of the centers who don't do a transplant, they will never talk to about transplants. And for good results, good outcomes, you have to travel to your all. Whatever we said, the neighborhood hospital will help you. But if they don't do a transplant, if they don't have a hematopathologist, that does not complete their hematology centers. And that's what the request to all of you is to remember that there are many doctors, there are many centers which are neighborhood doctors, neighborhood hospitals. But when it comes to hematology, one thing which has to resonate with you is Fortis Gurgaon, because it has been designed with 20 physicians, 30 nurses, 4 hematopathologists, and a genetic lab along with that to serve you the best. That's the whole idea of today's talk. I know you have already been burdened with all these Cancer Day specials, or all the awarenesses. But what we have learned today is who is a hematology. Lymphoma, myelomas, blood cancers needs to be treated by a hematologist who's qualified. We have a pediatric hematologist, Dr. Vikas Dua, who deals with thalassemia, sickle cell. Many of you will be in various places. In Odisha, Jharkhand, there's a sickle cell. Many of the contractors talks about sickle cell. Joint pains. We need to make aware. We need to make aware. Let's campaign for them that sickle cell is curable. Thalassemia is curable by bone marrow transplant, and that's why my colleague Dr. Vikas Dua does it. We also help pediatric patients by giving 25,000 rupees, the nutrition and everything, so that they have an equal chance to fare well. So with this intent of curing people, and with your support, with God's kindness, patient respects, and trust, we have been serving for hematology, which nobody else has been doing in this country to the scale which has been done now. I would thank everybody. I will open up for your questions. Next time we'll just have 8 cases to show you, and then we can have a rapid session round to ask about what are the diagnoses and what do you think about. But till that time, clinical annotation services are there with you. Please feel free to send your queries on a WhatsApp. Thank you, everybody.
Thank you, sir. Any questions, please? Any doctors, whoever want to ask?
So, Dr. Sushmita, you are a gynecologist, I heard.
Yes, sir, I'm a gynecologist.
So every pregnancy, you have to screen for thalassemia, Dr. Sushmita. And one more thing, you are a closed door people. NTPC, you have a control over people and where they come from. So the moment they get married, please start putting them on iron tablets. So my dear friends, whosoever is now going to attend the marriage, you have to tell to the bride in their ears to start iron tablets. Because the 90% of pregnancies happen during the first 2 years of marriage. And the female is still iron deficient, or called latent iron deficiency, which leads to the inferior development of the brain of the child when they come in.
Yes, sir. Recently, I got a patient. She's a spouse of NTPC employee. She had beta thalassemia trait. Uh, she underwent cesarean in a empaneled hospital. But the day she underwent cesarean, unfortunately, her elder son, he developed ITP, acute presentation of ITP, and he rushed to some other empaneled hospital. I don't know why it happened. There is no known cause of ITP. 7-year-old boy.
So, sir, madam, the only thing in ITP is to remember is don't worry about the platelets. As long as the platelets are more than 20,000, nothing to worry. If they're less than 20,000, you can still do the bone marrow test before starting the steroids. Always remember, for ITP, the request for IVIG will come. And there's a huge difference between IVIG procurement and the MRP. So you should always ask for some discounts from the hospital because IVIG in children is very good. It leads to a control in 80% times. But if they have to give steroids, please remember, if any person has to give steroids in hematology for ITP, please do the bone marrow test.
Okay, sir. Any questions? Many physicians have also joined, and
thank you, Dr. Susmita. Thank you, Dr. Rahul. This is Dr. Behra this side.
thank you, sir.
Thank you for addressing to our queries and enlightening us on the blood-related cancers. I just had a question that you told that is no prevention. Just now you just discussed with Dr. Sushmita that I think before marriage you can do counseling for beta thalassemia and sickle cell. So I think that's part of prevention. And what sort of prevention and what sort of tests do you recommend before you ensure that you do not have a child who is suffering from beta thalassemia or sickle cell?
So the simplest thing is those are non-malignant conditions. And we say blood cancer is no longer a death sentence, and you need not be worried about blood cancers, to be honest. Right. That's what the motto is, to be honest. Just don't worry. It's just another diabetes or something. For thalassemia trait, simplest thing is after marriage and before pregnancy, please check both husband and wife for thalassemia. Do the HPLC. I always tell people, I tell you a funny story. Probably I'm the only male in this world who sat 5 days back without his wife, who's back. I mean, I've been married for 20 years now. Who sat with his wife to create an account on shadi.com and bharatmatrimonial.com. And can anybody make out why did we make a account on there? Just to check whether there is any genetic counselings which are happening there. And to our surprise, there's no genetic counseling. That's why we have hired a geneticist so that throughout the day, he can counsel people. People can open up their lines and say, look, I have thalassemia trait. Should I get married to a thalassemia trait or not? Or you can, because love has got no boundaries. I can fall in love with anybody. It's not written over my head that I'm thalassemia trait. But fall in love responsibly. So simplest prevention is every mother, every father needs to be screened after pregnancy. So if the female goes to Dr. Sushmita at the ANC first antenatal visit, along with HIV, VDRL, she should also add HPLC to that. And I'll send you one simpler liners. I think Dr. Behra's number is there with me. I'll send one simpler liner, low MCV, low MCH, normal RDW, thalassemia trait. Low MCV, low MCH, prolonged RDW is iron deficiency anemia. So that way, we will be able to prevent thalassemic babies from being born. If somebody is in a Bareilly region, please spread out this word. Shout out on the top of the voice. We can't afford thalassemic kids. No organization, no country can afford thalassemic kids. They are preventable. So let's do that. Simple CBC and HPLC. Next time you visit to any marriage, instead of giving 501 rupees, As a shagun, please give 650 rupees.
जीन्स की कुंडली की जगह जीन्स को मिलाया जाए, ये मैं बहुत पहले लिखा था, और इसको शायद अगर अवेयर करें सभी लोगों को तो ज्यादा बेटर होगा।
हाँ सर, हम कहते हैं जन्म पत्री के साथ ब्लड पत्री भी मिलवा लो, या जेनेटिक पत्री भी मिलवा लो।
जेनेटिक पत्री होनी चाहिए।
हाँ, एब्सोल्युटली राइट सर। सर हम तो सोच रहे थे एस्ट्रोलॉजर्स को पकड़ ले, जब तक पब्लिक के पास नहीं पहुंचते तब तक एस्ट्रोलॉजर्स पकड़ ले जो कहेंगे साहब थैलेसीमिया की भी जांच करा लो। So blood cancer is curable provided the team which is handling makes all the difference in this world. But still 20% people will not be able to save, and we should try to make 80% live normally. Dear friends, any questions? Am I audible? Absolutely pin drop silence.
Yes, sir, you are audible. Actually, we are just listening to you. So, Dr. Sushmita, you can just conclude if there are no questions.
No, there are no. I think no one has any questions. Thank you, Dr. Bhargav, for telling us about the newer advancements. Actually, most of us are posted in remote places, and we are not aware of the advances. Since we attend our own conferences, we don't know about the other specialities. So most of the time, we do face problems when patients come and ask us where to go. And I think now, at least in hematology, we can advise them to go to you.
I just wanted to add something, Dr. Susmita, to you, that any hematology or blood cancers, we can have Dr. Rahul and Dr. Vikas there to help us, and I think they have all the facilities in FMRI, and they have a lot of scope in treating end to end. So they do not have to refer to any higher center for any further management also. So now we just have some more awareness sessions on this topic, I think, in
so
next week.
We have approach to anemia, sir. Simplest thing. And then the completely like a CME where they will discuss 10 cases, sir.
Right, sir. Thank you. Thank you so much.
And any is required, sir, please send your on a WhatsApp. We are always there. Even if the patient can't travel, we will manage with you.
Okay. Thank you, sir.
Thank you, ma'am.
Thank you for giving your valuable time to us, and for teaching us many of the things which we were not aware of. And do, sir, send the one-liners, because it will help at least us who are not physicians, and we have forgotten most of the hematology and other things of different specialties, and of MBBS also. We see the hemoglobin level, we see the MCH, we see the MCV, and that's it. I don't think I go to RDW also, but now that you have said, I'll see. And with that, at least we can diagnose that the patient might be having thalassemia trait. That was one learning for me. And definitely, sir, please do that webinar, the seminar on anemia.
Somebody has asked me my number. My number is 9958, sir.
9958
174
174
994.
994. Thank you, sir. Sir, do send the one-liners.
So, ma'am. So that I'll start today only. So Dr. Behra will get it. Sorry, sir. I'll be bombarding you with some WhatsApps.
Okay, sir.
Sure.
Thank you. Thank you on behalf of NTPC,
Sir,
on behalf of all
सर
the
नंबर
doctors.
एक बार दोबारा रिपीट कर देंगे
Sir, 9958
जी
174
जी
994.
थैंक यू सर
Thank you, sir.
And Dr. Behra, one more
So
request.
much
Dr.
thank-
Pawan Gupta has also shared his number, and he was showing one QR code which we were unable to scan at that time to join ICANN.
Yeah, ma'am. I'll let you know all the details of ICANN Care and I'll send you the details. Thank you.
Okay. You can close, Dr. Behra. Thank you. Thank you, one and all.
Thank
for
you so
attending
much.
today.
Thank you.
Thanks.
Thank you.